Listen now to a discussion Magnus Oman had with Dr. Anthony Gershlick, Professor of Cardiology at the Leicester University in the United Kingdom, and Dr. Deepak Bhatt, Professor of Medicine at Harvard and Director of Interventional Cardiology at the Brigham and Women's Hospital in Boston. They cover complete versus culprit lesion-only primary PCI, the Culprit Trial. Treat the infarct-related artery only or all lesions.
So welcome both of you to ACCEL.
Thank you.
So this is an area that is quite interesting because last year we had the primary trial, a single-center UK trial, suggesting that there may be some benefit with actually treating all the lesions at the time of primary PCI. Your trial, Tony, is a multi-center trial, so tell us a little bit about that.
This trial was conceived about 3 or 4 years ago when it struck me that not infrequently as interventional cardiologists during a primary PCI we see significant lesions in the non-infarct related artery. And there are multiple questions you can ask about such a scenario, including how do you estimate severity, when should you do it? But one of the base questions that I kept asking myself was, should I be doing what appears to be significant lesions now, or should I send them out and get a nuclear scan, or not do anything? So Culprit was thought up at about that time, about the same time as PRAMI, independently. And our basic hypothesis was there any benefit to doing all the lesions, the infarct-related artery and the stenoses that we thought may be significant in the non-infarct-related artery during that admission versus doing only the lesions as they came up? So our endpoint was MACE at 12 months. And our criteria was that you needed to have a significant stenosis in the non-infarct related artery that had to be 70% in one plane or more than 50% in 2 planes. And then patients were randomized whilst you were actually undertaking the primary PCI, so there was no case selection. You couldn't do the primary PCI and say, I didn't fancy doing this. And then we asked most people to try and do them at the index PCI, so 59% got done at the time. The clinician could choose to stage sitting, but it had to be done as an inpatient. So there was clinician decision around 2 o'clock in the morning. The patient wasn't so well. We would defer it, but they had to be done on that admission.
So in a way, to some extent, some patients mimicked and Deepak the U.S. practice, which is somewhat staged, even though 59 had it at the same, which is a class 3 indication by the American Cardiology Guideline. Tell us a little bit how you see that issue with staged setting of primary PCI.
Sure. Well, first of all, I have to say this was an outstanding trial. The conduct was outstanding, the design, the execution. So the results, I think, are certainly believable and do build upon PRAMI, which was also a well-done trial, but the limitation of being single-center. So with 2 trials now showing philosophically the same thing, I think we've got to believe the data. I guess I would also add that in some respects it confirms my own biases and beliefs and long-standing practice. But I should say long-standing practice more remotely. That is, I used to always do this. That is, if someone came in with an LAD infarct, obviously treat the culprit, and then if they had an RCA lesion, stage it. Most often, unless they were in shock or something, that would be during that index hospital admission a day or 2 afterwards, depending on their creatinine and cath lab scheduling and other issues. Sometimes during that same procedure, if it looked like it was a slam dunk lesion, but less often that, especially since the guidelines would have said not to do that. So that had been my practice for many years, but more recently there's been, I think, some pressure to even not do the staged intervention during that index admission, but rather discharge and monitor for symptoms and or ischemia and only then bring them back to the cath lab. So I think that practices have become more conservative in the U.S., in part due to guideline considerations, in part due to just third-party payer considerations.
So it's important to point out, though, isn't it, Tony, that all your patients were excluded if they had shock, right?
Yeah, no cardiogenic shock. And I'll just make a short comment on what we've just heard, and I think it's absolutely right. Much of the guidelines are based on the registry data. And for registry patients, there's a huge amount of selection. If we look at the Hanan data, for example, only 20% or so, maybe even 14%, actually had their procedure all done at the time of the primary PCI, and they were selected patients. They were the sickest patients. And we all believe if a sick patient comes in, particularly cardiogenic shock, we should treat everything. So if the patient died, it may not be because you were treating everything, but because the patient was sicker, which made you feel you needed to treat everything.
So let's back to your study. So how many patients did you randomize?
So we randomized in total 289. So this was powered on the Politi data, the DiMario data, and another small trial. So we did the power calculations, and people have talked about the small trial. I mean, I'm not sure how big a trial you need to show a biological benefit. We can talk about multiple trials and regression to the mean for any study in a small trial, but the truth is this was powered for 144 patients per group based on the composite endpoint, and we showed this 55% reduction across all the endpoints. It was an open-label trial, so it's up for criticism for it being open-label. Patients knew they had a lesion that wasn't treated. But if we do the analysis, which we have done, for death, MI, and heart failure, there's still a significant difference. So this is not dependent just on someone believing the patient got a bit of chest pain and they want to do the non-infarct related artery.
Right. So tell us a little bit about the components of the primary endpoint.
So it was all-cause mortality, a hard endpoint for re-AMI. We didn't want to pick up enzyme bumps. It was readmission for heart failure. Again, you had to be readmitted. You looked at the adjudications. They were independently adjudicated. And need for revascularization. So in other words, you need to have two medications. You preferably had a non-invasive test, but most of the patients who were revascularized were admitted with chest pain as an acute coronary syndrome and were treated on that basis. So we do have some sub-studies as well, which will maybe give us some insights into. Maybe we can talk about that.
Deepak, this is always an interesting question. Now we have two UK trials, very impressive in aggregate, and Tony, yours have very high quality features to it. How should we inform ourselves around guidelines in this sort of setting? It's ex-US, which is always the challenge that we think about this, but what are your thoughts?
So, the international aspect to it, in this case UK specific, I don't think is a factor. In certain trials and issues, it could be if it was a trial of a new medicine versus an old medicine and the background therapies aren't comparable in the two different countries, then it might be legitimate, but I don't see why for a stenting trial in STEMI it should make any difference. There is a larger trial going on that is being coordinated by McMaster University, the COMPLETE trial, and full disclosure, I'm on the data safety monitoring board of that trial, that's examining the issue of culprit only versus complete revascularization. So there's at least that trial and perhaps others going on. I guess I'm inclined to believe these two trials, PRIME and now culprit, because in a sense it's a confirmation bias. My own honest belief is that complete revascularization in these high-risk patients who prove that they themselves can rupture plaque, I think stenting the other lesions prevents future myocardial infarction and at a minimum prevents future urgent revascularizations.
Yeah, I think this is a really important point that's being made here. I think that we know that patients with acute coronary syndrome that have other lesions do worse than patients with stable angina who have other lesions. So maybe these index non-infarct-related stenosis are not as stable as people think that we can postulate about pan-inflammatory and all those other things. But, maybe just because they look stable, they are not stable in this environment.
And there's that data from Mike Gibson at Harvard that looked at the flow in the non-infarct vessel that has always been reduced, and we've always wondered, why is this? And we haven't got a good explanation for it. That's a very interesting observation. Now, what about downside to this? Obviously, bleeding, amount of dye used. Were there any downsides to this?
Yeah, there certainly was more dye used and the procedure was longer, but there were no adverse safety signals at all. There was no excess of CIN, there was no excess of bleeding. Now, this sort of talks somewhat to our desire to do the same procedure, providing the clinician felt it was safe to do so, because, we didn't want the patient to have a second puncture, even if it's in the same admission, and sometimes the dye load in vulnerable patient, the effects of it on renal function happen 2 to 3 days later, just when you're going back to do the repeat procedure.
So what you're saying is that there may have been some selection bias, that the 80-year-old with renal insufficiency may not have got into this trial.
Well, they would have got in, but they may have had their procedure delayed. And what we didn't do, and a big mistake, was to ask the physicians why they didn't want to do it at the time. Just one tiny comment about the COMPLETE trial. The other thing we found was that many of the curves separate early, And I think for the CvLPRIT trial, there is deferring to an outpatient to bring them back. And I think you may, if you do that, potentially miss some of the separation of the curves. You may be gaining adverse events whilst you're waiting to bring the patient back.
I guess from the CvLPRIT trial perspective, the two endpoints, sort of very hard endpoints, death and MI, were not individually statistically reduced. Yeah. So there's still some leeway here on how we can see that.
Absolutely, but I would agree that it remains a little bit of an open question also when that second PCI of that non-culprit lesion should be done. Should it be done during that index procedure or later on during that hospitalization? And I think as was done in the trial, good physician judgment would need to be employed. So if the creatinine is really high and it's a complex non-culprit lesion, probably better to stage it. But likewise, the timing of staging also requires some thought because, yes, contrast nephropathy may not kick in for a couple of days.
It's a great point. I don't think you need to do that trial. I don't think you need to do index procedure versus index admission because I think clinicians can make that judgment. I think there are trials to be done, including FFR, to see whether or not, or virtual histology to determine vulnerability of the plaques and the flow in the non-infarct related artery. So that's a trial. And I think there's still a place for understanding who to do and when to do it. So I think there are trials. I'm just anxious that the CvLPRIT study won't provide us with the answer. So I think there's plenty of place here for further big studies.
Well, this has been a great discussion. So we're incrementally going towards CvLPRIT. Really appreciate both of your time here. Thank you.
Thank you very much.
Thank you very much.